Dear ladies and gentlemen, welcome to another talk brought to you by the Malaysian Obstetric Medicine Society. The title of our talk today is It Takes Two to Tango. Now, ladies and gentlemen, what I would like to highlight in the talk today is about paternal medicine and how important is paternal health with regards to optimal obstetric outcomes. Now, ladies and gentlemen, this is not something new. I think for many years, we have purely been focusing, stigmatizing mothers with regards to her health, to her age, to her BMI. But we have forgotten the elephant in the room, which is often also the health of the father. And that brings to the talk today paternal medicine, because obviously, ladies and gentlemen, it takes two to tango. I'd like to declare that I've got no conflict in this talk, but I've got a huge lot of interest with regards to high risk pregnancy, especially placental syndromes, and what else affects placental syndromes rather than the health of the mother, the health of the father. Now, ladies and gentlemen, although we are discussing now that paternal medicine is an important part in obstetrics, I'd like to highlight that although we should be paternal in our approach, we should move away from a paternalistic approach because it's always important to include the woman in the management. It is important to know her option, her perception, and involve her in decision making. Now, the paternal medicine, ladies and gentlemen, is not something new. Now, this paper, published almost 2 decades ago, rightfully said that among the many etiologies of preeclampsia, the father has got a significant role to play. And this we knew almost 2 decades ago. But now, this wonderful paper, published in 2019 in the Obstetric Medicine Journal by A. Kotari, sealed the importance. And this paper titled The Forgotten Father in Obstetric Medicine. And this is a wonderful paper that I would like to strongly encourage everyone to read. And that brings to the talk today paternal medicine. Now, ladies and gentlemen, in the next 25 minutes, I'm going to share two clinical vignettes. The important concept of epigenetic integrity, which is going to link the health of the father and the implications of the offspring. Paternal inheritance of diseases that every single obstetrician should know. The association between paternal health and pregnancy outcomes, and what we should be doing from here onwards, moving forward with regards to paternal health. Let me share true stories. Now, this is a patient that I managed 3 years ago. She's a 36-year-old homemaker, had two previous uncomplicated term deliveries, delivering healthy babies. She had no previous preeclampsia. She has got no underlying medical illnesses. Her BMI was normal 29. Her last childbirth was 2016. In this pregnancy, ladies and gentlemen, to everyone's surprise, she presented with severe hypertension. Her blood pressure was 180 over 110 at 26 weeks. She was symptomatic. The fetus was suspected. It was an abnormal Doppler with 520 flaps. Now, ladies and gentlemen, severe preeclampsia at 26 weeks. We had to deliver her for maternal indications. It lost that pregnancy. And it was an obstetric dilemma. And I questioned myself, why is a healthy mother in a third pregnancy with a normal BMI who's relatively young developed preeclampsia? We spoke about placental syndromes. We spoke about aspirin. We spoke about low molecular weight heparin. We even spoke about screening for antiphospholipid syndrome. Then asked the one question: who was the father of this child? And this was a pregnancy conceived with a boyfriend. And hence, ladies and gentlemen, the puzzle was complete. It was the new partner that gave rise to a preeclampsia, and that was the reason why she developed severe early onset preeclampsia. Let's take a look at clinical vignette number 2. It was an unfortunate patient that I managed a year ago. She's a 28-year-old reporter. She had a miscarriage in 2015. She unfortunately had a second pregnancy loss, this time a 19-week fetal loss in 2017. In 2018, someone thought that she had a cervical cause for her pregnancy loss. She had an emergency cervical cerclage, but still miscarried at 22 weeks. The last three pregnancies were IVF pregnancy, and this was also an IVF pregnancy. So she came to me being referred by another doctor. She had normal cervical lengths from 14 to 18 weeks. Unfortunately, during a routine review, her cervix was shortened at 1.8 centimeters at 18 weeks. And so she had an ultrasound indicated cerclage. Unfortunately, despite having a cervical cerclage at 18 weeks, she miscarried at 21 weeks. There were no signs of infection. The placental histology showed no chronic intervenous histiocytes. The placental CNS showed no infection. I was perplexed. Why did the pregnancy fail? Why did the cerclage fail? I asked her one question: tell me more about this IVF pregnancy. Then I realized this was a pregnancy conceived via a donor egg and a donor sperm. And I believe the pregnancy was lost because of a placental syndrome. It was her body rejecting the pregnancy and the placenta, eventually causing a pregnancy loss. It was not the infection. It was not the cervix. The cervix was innocent. It was a placental syndrome because of a donated sperm. So, with that, ladies and gentlemen, I would like to highlight the association of paternal health with placental syndromes, which is going to be the gist of the talk today. The importance of paternal health and the blood group, especially with regards to rhesus negative mother, how the health of the partner, the father, may inherit certain genetic conditions to the offsprings, and how the age of the father has got some association with fetal genetic conditions, and of course, association between paternal health and perinatal mental health. These 4 points. But the most important point is going to be the association between paternal health and placental syndromes. Now, ladies and gentlemen, to understand this better, the magic word is epigenetic integrity. And the second magic word is epigenetic reprogramming. Now, it is quite clear now, ladies and gentlemen, that there is a significant association between poor sperm quality with poor pregnancy outcomes. And this has been beautifully been highlighted by the paper I quoted earlier, 2019. Now, what causes poor sperm quality? A father who has got significant medical condition, example, diabetes. A father who's taking significant lots of medications that suppresses the sperm quality. A father who's at an advanced age beyond the age of 35 has got poor sperm quality. A father who's obese, a father who smokes, a father who consumes alcohol, all associated with poor sperm quality. So the next time you label someone as an advanced maternal age, that does not stigmatize the mother. The age of the father is just as important as the age of the mother, because that contributes to epigenetic integrity. So, ladies and gentlemen, if the father is under-neutralized, under-nutrient, the father is obese, the father is undergoing tremendous amount of stress, the father smokes, all of which can be reversed by exercise, vitamins, and weight loss. These factors in the father's health causes epigenetic integrity, and this affects DNA methylation, affects histions, affects RNA, and the problem lies in the error of the pre-meiosis, and this causes poor sperm function. Now, poor sperm function causes poor placental quality, and that significantly affects the health of the offsprings, where the baby later on in adult age has got a higher incidence of obesity, insulin resistance, type 2 diabetes, and heart disease. So if an individual develops diabetes, ladies and gentlemen, it is usually the intrauterine environment. It is also the health of the father and the mother. And that is the gist of epigenetic integrity. So once again, if the health of the father is not optimal, there's a significant reduction in epigenome reprogramming, which disrupts the integrity. There's a huge load of pre-meiotic damage, namely the histions, namely the epigenetic reprogramming, and that causes miscarriage and birth defects. That also causes a significant neuropsychiatric disorders in later lives of the offspring. That also increases the chances of malignancies in adulthood, and that significantly affects the health of the offspring, and that can also cause placental symptoms. Ladies and gentlemen, the age of the father has got a significant association with autism, especially the father's aged beyond 45. I think this is associated with poor sperm quality, affecting epigenetic integrity, affecting epigenetic reprogramming, and that causes all the associations which I mentioned earlier. What are the paternal inheritance of disease? It's not just what diseases the mother inherits, but the important Y gene also inherits a lot of conditions. It can be Y chromosome microdeletions. It can be cystic fibrosis, Klinefelter, Prader-Willi, Huntington's disease, most muscular disorders, spinocerebellar ataxia, spinal and bulbar muscular atrophies are all inherited from the father. Now, this may cause subfertility. So rather than asking why was he subfertile, it's also important to screen whether the father is subfertile secondary to an underlying genetic condition. The solution is not just IVF. The solution is not just IVF plus ICSI, but the solution is to exclude a genetic cause, especially if it's a subfertility secondary to a male factor, especially if the partner is a zoosporic. Preeclampsia. Almost 2 decades ago, Gus Decker wonderfully highlighted in his paper that it is the couple's disease, and that remains true up to today, ladies and gentlemen. If the father has child, a previous baby with preeclampsia, future pregnancies, there's 2 times higher risk of fathering another child with preeclampsia. So for all women at booking, ask the woman 2 questions. Has your mother got preeclampsia? If a mother has got preeclampsia, she's got a significant risk of preeclampsia now. Has your husband fathered a previous child with preeclampsia? The answer is yes, she's got a significant high risk of developing preeclampsia once again. Second, ladies and gentlemen, is the interval between marriage to the first pregnancy. Now, there's no magic number. And some people say that the longer someone stays in that marriage, the more she desensitizes herself to the husband's foreign body called the sperm, the lower the incidence of preeclampsia. There's one study that said everyone should co-inhabit it for at least 6 months before conceiving, or at least 30 sexual acts. And that seems to be protective against preeclampsia. So short duration exposure to seminal fluid is not recommended. The recommended period is 30 sexual acts and then to conceive and have a first child. On the other hand, the longer the interval, an interval beyond 10 months, rather than desensitization, there's loss of sensitization, and that can also predispose to preeclampsia. And certain contraceptive methods, barrier contraception is not as protective as other methods of contraception, namely the oral contraceptive pill. So, ladies and gentlemen, I'm not telling couples not to use barrier contraceptive use. I'm asking them to use contraception, but to live together for at least a period of 6 months before they think and embark on the first pregnancy. Now, the incidence of preeclampsia has also increased if the mother conceives from an ovum donation, which is the third cell line, or an azoospermic donor who may inherit certain genetic conditions, or the pregnancy is conceived from a sperm donor, and that may also predispose to preeclampsia. So the next time you have a patient with IVF pregnancy, please ask her some details. Is it IVF alone or is it IVF plus ICSI? If it's ICSI, was the husband a zoospermic? Have we excluded some genetic conditions? Is it her own egg? Is it the husband's own sperm? Because all of this is going to affect, contribute to placental syndromes, something like what happened to my second patient. Now, of course, ladies and gentlemen, if the husband has got some STDs, the husband has got herpes or CMV, that is going to cause placental syndromes, preeclampsia. So the husband, the father, has to be as healthy as possible. We often talk about advanced maternal age. What is the association of advanced paternal age? Now, ladies and gentlemen, this wonderful paper by Yash Kandwala looked into the association of paternal age with perinatal outcomes for a good 12 years in the United States. And they realized if the husband or the father is at an advanced age of above 45, there are lower pregnancy rates. The miscarriage rates can be up to 32%, equivalent to a mother at the age of above 40. There's a significant association with low birth weight. I believe it is growth restriction as high as 19%. The incidence of preterm delivery is high as 29%. Once again, not because of a placental cause, not because of a cervical cause, but rather because of a placental cause causing placental syndromes. The incidence of stillbirth can be as high as 1 in 2. The father's above 45, and indirectly, there's a higher incidence of low APGAR score. So, ladies and gentlemen, we should stop labeling our mothers as advanced maternal age. It's not just the age of the mother that matters, it is also the age of the father. Now, what is the optimal age of the partner to reduce maternal complications? We did correlate earlier that the age of the father may cause preeclampsia, eclampsia, hypertension, abruption, and placental previa. So the optimal age of a partner to conceive should be before the age of 35, and that seems to be the safest for the mother, especially with regards to placental syndromes and placental complications and preeclampsia. What is the optimal age of the father to prevent fetal complications, namely low birth weight, preterm delivery, stillbirths, and fetal growth restriction? Once again, the age of 35 seems to be the magic value. So just as much as society have wanted women to conceive before the age of 35, I think it's also important to highlight and educate that as much as we want the mother to conceive before 35, the father should also be able to be at a younger age group before 35 to prevent maternal and fetal complications. What if the father consumes alcohol, ladies and gentlemen? This wonderful paper looked into the alterations in the sperm-inherited non-coding RNAs, and that association, which is associated with alcohol consumption pre-pregnancy, is associated with fetal growth restriction. So it's important that the father does not consume alcohol, not just pre-pregnancy, but also during pregnancy, which seems to be of importance, especially in terms of lifestyle. What about smoking, ladies and gentlemen? We often ask our pregnant mothers not to smoke, failing to realize that passive smoking is just as notorious as active smoking, because passive smoking in pregnancy is associated with stillbirth, is associated with aneuploidy and structural defects, is associated with preterm deliveries, related deaths as high as 5 to 8%, is associated with low birth weight, and of course, it's associated with socioeconomic implications. So she advised the father to stop smoking pre-pregnancy to prevent low sperm quality. We should also advise the father not to smoke during pregnancy because passive smoking is associated with adverse pregnancy outcomes. What about paternal BMI? We often document the mother's BMI in the antenatal red book, but this wonderful paper looking into paternal BMI and adverse pregnancy outcomes in China did show an association between paternal weight and fetal outcomes. This study beautifully concluded that pre-pregnancy maternal and pre-pregnancy paternal BMI are both independently and combined increases the risk of adverse pregnancy outcomes, such as preterm, low birth weight, macrostomia, stillbirths, and birth defects. So, ladies and gentlemen, the pre-pregnancy clinic, when you're asking the mother to reduce weight, when you're documenting the mother's BMI, also don't forget to ask the father to reduce weight, document his BMI as well, because that is also just as important as maternal BMI. How about paternal exposure to medications? The father is on chemotherapy. The father is taking methotrexate. The father is taking MMF. The father is taking leflunomide or mercaptopurine or cyclophosphamide. This may also affect sperm quality, and that poor sperm quality may also cause placental syndromes and adverse pregnancy outcomes. So, ladies and gentlemen, it is not often always that we should ask the father to stop medications. But the principle is to follow the principle of 2 sperm cycles. 1 sperm cycle lasts for 30 days. 2 sperm cycles is 60 days. So option number 1, if you've got a father who's going to plan a pregnancy, try to get the lowest possible dose for optimal pregnancy outcomes. But if that particular medication, namely the medication that's listed in this small table, is associated with poor sperm quality, then perhaps apart from a lowest dose, he may opt to not to take this medication for a short period of 60 days or 2 sperm cycles, plan the pregnancy, conceive, and then restart the medications. If you're not sure about what medications in the father causes adverse pregnancy outcomes, I would recommend that you go to this site, BUMS, which is my favorite site in pregnancy, which talks about best use of medications used in pregnancy. But the moral of the story, ladies and gentlemen, the principle is 2 sperm cycles, lowest possible dose of certain medications in the father, avoid it pre-conception if there is a safe option. How about paternal exposure to toxins? The father is exposed to organic solvents. There is an association with anemia, not just folic deficiency in the mother. The father is exposed to phytates. There's an association with cardiac diseases in the fetus, namely VSD and pulmonary stenosis. The father is exposed to alkyl-phenolic compounds. There's an association with fetal heart defects, herbicides with fetal cancers, namely astrocytoma, and pesticides association with astroglio brain tumors. So the environment that a couple lives in, the environmental exposure, the paternal occupation are all important considerations that one should take into consideration in the pre-pregnancy clinic, because as much as healthy you would like the mother to be, similar weightage should be given to the health of the father for optimal pregnancy outcomes. And that is the gist of modern obstetrics. How about intimate partner violence? Now, this wonderful study in BJOP looked into intimate partner violence and adverse pregnancy outcomes, ladies and gentlemen. It looked into physical violence, emotional violence, and sexual violence. And there is an association. If the father has got a mental health, they live in a non-conducive relationship, the incidence of perinatal mental health and adverse pregnancy outcomes, especially stillbirths, preterm deliveries, are increased. Because the stress and mental health not only affects pregnancy intrauterine, but also causes offspring behavioral pattern abnormalities and long-term neuropsychiatric diseases in the long term. So mental health, both of the couple, a stable, healthy relationship is extremely important for optimal pregnancy outcomes. So what is important apart from not staying in a domestic violence or having a stable relationship? If your partner is supportive, likely the compliance of the mother during pregnancy is improved. Likely the experience will be more positive. We have came to a time where the partner often accompanies the mother during labor. That we know has got positive pregnancy implications. But perhaps the partner should also accompany the mother to the pre-pregnancy clinic and every single antenatal visit. It is important that the support of the partner is important for the mother to cope with adverse outcomes, especially with regards to breastfeeding, especially with regards to requirement of analgesia. And all this, a supportive partner not only leads to a positive pregnancy outcome, but also leads to a positive pregnancy experience. There's one condition, ladies and gentlemen, called the COVID syndrome. We spoke about what conditions in the father affects the pregnancy. How can the pregnancy affect the father? Apart from having significant financial implications, a father may also suffer from significant hyperemesis gravidarum, and that is often called a COVID syndrome. Now, this is hypothesized by certain factors, namely somatized anxiety in the father. It is a way, perhaps, how the father identifies the fetus. It's an ambivalence of the father with regards to fatherhood. It is perhaps also a statement of paternity, or perhaps also a parturition envy. Although we do clearly know that there's a genetic predisposition to hyperemesis in the mother, with regards to why the father vomits is known as a COVID syndrome, although this remains hypothesis, there's yet to be a conclusive physiological definition. But yes, the pregnancy can affect the father as well. So, ladies and gentlemen, I believe I've highlighted the importance of paternal health and the association and implications with regards to pregnancy outcomes. But I believe it's only going to get worse from here. We're going to have more single similar gender marriages. We're going to have more patients embarking on a pregnancy at a later age. We're going to have more patients with subfertility. We're going to have more sperm donors. And I believe it is now that we focus our attention towards a more holistic approach and incorporate paternal medicine in our daily obstetric practice. So moving forward, ladies and gentlemen, as obstetricians, especially in the pre-pregnancy clinic, involve the partner in consultation. Pre-pregnancy clinic is no longer just for men, no longer just for women. It should be for the couple. See the mother, see her partner, see the future couple together. If there's subfertility, do not just subject them to an IVF or an ICSI. Think of paternal inheritance. Ask her why is he subfertile, because that genetic condition may be transpired to the child. Fetal anomaly often don't just blame the mother. It may be a couple's disease. Does the father smoke? Does he consume alcohol? What is his BMI? What is his age? There may be an exposure, especially if he lives in a toxic environment or there's been some environmental exposure. Placental syndromes, like what Gus Decker beautifully summarized 2 decades ago. It is a couple's disease, ladies and gentlemen. Just like how it causes miscarriage, placental syndromes, pregnancy failures, preterm deliveries, and fetal loss. It is often not a cervical cause, it is often a placental cause, and that this is how the importance of the healthy mother has got an association. The health of the father also has got a significant association. And we should stop labeling women as at advanced age, because if she is at age of 35, the husband is at the age of 45, that is also associated with significant outcomes. It should be the age of the couple, not just the age of the mother. So, ladies and gentlemen, with that, we should remove barriers that prevent fathers from coming to consultation. We should remove policies that prevent husbands that come to the clinic. It's all about policies. It's also about societies that have stigmatized women. It's all about community. It's all about family. It goes back to the individual. It's important to see the couple together in the obstetric clinic. So with that, I'm going to summarize 10 key facts for preconception care for men. Number one, the next time you see any man in your clinic or any couple, it's important to plan and have a reproductive life plan. It is important to counsel the husband not to have sexually transmitted diseases, namely herpes and CMV, because that's got significant association with preeclampsia. The husband should stop smoking, especially before conception and during pregnancy, should not abuse substance, should stop drinking alcohol. There should not be any toxic substance or work in a toxic environment. If the husband is taking some medications, use the concept of 2 sperm cycles or a 60-day theory if there is a reasonable, safe alternative to the partner's health, because good sperm quality not only improves pregnancy outcomes, it also reduces placental syndromes and prevents IUGR, preterm delivery, and preeclampsia. The husband is subfertile, if the husband is azoospermic, don't just look for the solution, but look for the problem, because exclude a genetic cause. Talk about healthy age below 35. Talk about healthy weight, a normal BMI, both for the husband and for the father, because an obese father has got similar implications just like an obese mother. Go into family history. Has her mother has got preeclampsia? Has the father child of baby with preeclampsia? Those are important parts of history. Get and screen into domestic violence. Screen for mental health. A supportive partner is extremely important, not just for a good pregnancy outcome, but for a good pregnancy experience as well. So, ladies and gentlemen, with that, I would like to summarize. It takes two to tango, and paternal health affects pregnancy outcomes and offsprings, a fact that I hope we can appreciate now. I think we as a society should improve patients and public's awareness. We should move away from blaming women. We should include the father in the consultation, because it takes two to tango. Healthy parents, normal BMI, good nutrition, healthy lifestyle, stop smoking and alcohol are important for both couples for good pregnancy outcomes. Sperm quality affects pregnancy outcomes, affects the mother, affects offsprings. So poor sperm quality is associated with epigenetic integrity, and that causes placental syndromes. Placental syndromes, ladies and gentlemen, are the leading cause of preterm delivery, preeclampsia, and prematurity. I think we should try to prevent. It is not just aspirin. It is not just medications. Sometimes we need to manage and approach it holistically, which is the health of the couple. We should screen for domestic violence. We, moving forward, obstetricians, should integrate men's health in our obstetric care, because paternal medicine is here to stay. And let us stop stigmatizing women for adverse pregnancy outcomes. Often, when there's a placental syndrome, it is both of them who is involved, and that herein lies the solution for optimal obstetric outcomes. With that, ladies and gentlemen, I would like to thank you so much for your attention. If you do need more information, kindly log on to www.obstetricmedicine.my. Follow us in our Facebook page. Follow us on our Twitter, MunizG at Twitter, where you can continue to stay tuned for more lectures in this YouTube channel. With that, thank you so much for your kind attention.